Now we would like to start panel discussion. I would like to invite our moderator, Dr. Ganesh Bakshi, sir, Professor Uro-oncology at PD Hinduja Hospital, Mumbai. I would like to invite panelists for this discussion. Dr. TB Yuvraj, sir, Head Robotic Surgery, Consultant Uro-oncology at Kokilaben Dhirubhai Hamani Hospital, Mumbai. Dr. Tarachand Gupta, sir, Consultant Medical Oncologist at Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Supriya Malik, Associate Professor, Department of Radiation Oncology, AIIMS, New Delhi. Dr. Aditya Pradhan, Director, Uro-oncology and Renal Transplant, Venkateshwara Hospital, Delhi. Dr. Naman Utreja, Consultant Radiation Oncology at Max Shalimar Bagh.
Good morning. Thank you so much. And a lot of the abstracts were presented in a very good manner, actually. A lot of good discussion has taken place. So I have a very august panel sitting here, and we'll try to get some practical points or get to real world practice. Dr. Supriya is actually not on the stage. Sorry. So I asked Shanky. So I've just taken paper after paper. So this was SWOG S1011, and not going into all this. So this debate about lymph node dissection in radical cystectomy has been going on. Number of lymph nodes or lymph node density, whether to do which template. So Dr. Aditya sir, the first two questions to you. Does a PLND or a technically help, or anyways we see poor prognosis in them?
Yeah. So your first question, just pelvic.
I mean, we have had a lot of discussion in between also since the abstract. So I'm just filling up, and let's have a meaningful thing.
Yeah. So the first question, yes, lymph node dissection does help. We are doing it. The question is the extent which this trial has showed you. That the extent is probably unimportant. Standard seems to be as good as extended. Though we had earlier thought that extended is going to be beneficial. So this paper is trying to tell us that the standard is adequate. So question one, does it help? Yes, it doesn't. The second question, does it always have a poor prognosis? This question is not yet answered. And N1 probably is not going to be treated only by surgery. You're going to add therapy to that. So today, you just take an isolation that N1 denotes poor prognosis. We don't have data to answer.
So generally, node positive bladder cancer does bad prognostically. So Dr. Umesh, here both the groups had 57% of neoadjuvant chemotherapy. It's quite comparable. Do you think it adds up into what we see, no difference in the final results? Dr. Umesh is not there. So. Yuvraj is there. So, Yuvraj, any take on that? And the next
No, questions? I think that was a good paper. Only thing is clinically how to apply in our patients. If you see, does PLND help at all? So now we are going from, we went from a limited to a standard to a extended to a super extended, and we are coming back again. So now, in the era of neoadjuvant chemotherapy, is it necessary to do a lymph node dissection? That is a controversial point. I think the time will tell. I think that the study should include only patients undergoing NAC for the trial. So I think this is a mixed bag. So it's very difficult to conclude which is going to be useful for us. And so I think, so the separate study will be required for that. So as of now, whatever we are doing in the clinically, there is a standard lymph node dissection. So what we call it as, so it's a must according to this thing, and extended is according to the clinical stage.
So maybe for this study, they should have a subgroups analysis into NAC versus non-NAC.
No, I think majority of our patients are undergoing NAC. So I think it's a time when this study was.
We will definitely come to know the remaining 33% or 43% what has happened and what would be. So Yuvraj, one more question. Like this keeps on happening. Even the peri-op mortality and morbidity rate was more in extended PLND. I mean, as you said, you have gone through everything. So is it really difficult to do extended LND?
And it's a very good question. As surgeons, we never had any difficulty.
And do you really see complications on table?
My just opinion. So we never had any mortality because of lymph node dissection. Of course, morbidity of a increased lymphoria is the only one thing which we can think of. But the thing is that if you see this paper, the extended PLND, they included the nodes along the IVC, that means infra mesenteric artery, below the inferior mesenteric artery. Actually, we call it as a super extended, PLND, not extended. Extended includes only the common iliac and a presacral. If you do it in extended, which includes common iliac and presacral, there is no increase in the morbidity or mortality. But if you include go up to the inferior mesenteric artery, definitely we can expect, because it takes more time. Most probably the complication might be high. I have not done it. I think the people can answer.
So maybe
Whether-
the complication seen at the most would be a lymphocele or something,
Oh, yeah.
unless you are not very good with the surgical anatomy and actually creating.
Difficult to believe that, significantly higher mortality. I don't agree with that.
Sir, you are saying something? Pati. So till then, okay.
No, as Yuvraj said, I had witnessed this, extended radical cystectomy, lymph node dissection from inferior mesenteric artery. That was with Donald Skinner. He was a great proponent of this, and he had produced the results that his results could not be matched anywhere. Obviously, with that, as the time progressed, it really withered off. But he was the great proponent of this.
So, Aditya sir, today would you keep a differential policy if you are giving NACT to T3AN0 versus N plus patients downstaging and then operating? Would you keep a differential policy towards standard versus extended?
I think I'll add one more caveat here, Ganesh. We are in almost all our patients, we are doing an FDG PET pre-operative,
Right.
which these papers don't mention. Their staging on notes is purely CT or MRI based size
Okay.
criteria. So we tend to get a little more biased. We have the advantage of a prior knowledge of what your notes are showing or not showing on the FDG PET. Consequently, we tend to be more aggressive if there is a positive and less aggressive in the absence. So I'll say if I have a node negative on a pre-op FDG PET, I will not do an extra. I'll
Sir, but
just do a standard.
there can be some fallacies with FDG
could
PET
be, I
also,
agree.
and you will
I-
lose some patients.
I agree with you, but in our practice, we are just following standard
Okay.
as far as but if it's extensive disease, large volume lymph node disease, we will go extra.
So I think as of now, probably everybody will keep this in mind. So these are the next two papers, UGN 101, the initial open label single arm phase 3. This has been presented, so I am not discussing this. And the durability of response to primary chemoablation. So it is primary chemoablation. The study had diagnostic ureteroscopy, and wherever the tumors were 1.5 centimeters and above, they were rendered smaller with a procedure which may be a laser ablation or something, and then given this treatment. So this has been presented. Coming to the questions. Upper tract urothelial cancer, it is a rare cancer. So, Dr. Yuvraj, how do you manage them? The drug is not here, as Dr. Gupta sir said.
Yeah, so I think as of now, we are not doing anything like this. We are just doing
So just a thing, you have a low grade in the ureter.
low-grade ureteric cancer. We do a laser ablation, and in adjuvant, we just put a ureteric catheter and give mitomycin. But we don't know how. This is a practical scenario. We are not going to. We just put a ureteric catheter and instill it for say 15-20 minutes and then stop it.
And any follow-up installations as chosen here, 6?
No,
Six
we
were
give only
given
one
here.
cycle. We don't
Aditya
give
Pradhan
six.
sir, anything?
In this particular paper which we are discussing, these were very, very selected patients.
Yeah.
All of them were actually only pelvis and calyceal lesions. There's no ureteric things which have been discussed. Second is that the size of the tumor which
Less
was
than
taken with was
one.
less than
15 millimeters.
less than that. That's what they've taken, less than 15 or 18, whatever they've done. And then they have given, just like bladder, 6 weekly installations, and then found that the toxicity profile is very extensive, or 25 to 27.
So if I interrupt you, giving 6 times in the 6 weeks, that's why I've written this. It's quite tedious. You will have to take the patient under
Absolutely.
general anesthesia every time in the operation theater. It's a kind of a major urological procedure again.
So this was, and so what we are trying to say is at the cost of 20 to 30% stricture and UTI rate versus ablation like what Dr. Yuvraj was mentioning. It's going to be difficult for us to accept this as easy to do modality for a very low risk upper tract disease.
Okay, but the drug somewhere seems wishful thing. So Yuvraj, what are your comments about this? This question number 5.
I think if it is available,
we don't have anything.
Yeah, so I think if the drug becomes available and we can do it, it looks attractive. Just put a gel.
Looks attractive.
Yeah.
Looks attractive. And as
the only thing is it's not a one-off treatment. It's not just one installation. Like they have been doing the bladder regimen 6 weekly and then a maintenance. And they have had only 1 patient or 2 patients in that entire series who have reached maintenance. So it just points to the fact that it's easier said than done.
I'd like to make a comment.
Yes, sir.
We are working in India. So the compliance of the patient, how many times he's going to come back for the maintenance? Every time you're doing ureteroscopy or putting a urinary catheter and gel and all that. So I think so we have to see the practicability of the therapy also.
Even in this series, 70 patients.
Should be very carefully selected case, low grade only. You cannot use this treatment in high grade tumor.
I guess every of these patients should also need to be explained about the repeated intensive procedures and the cost of it. Because apart from finishing therapy, this protocol also involves a check ureteroscopy at 3 months, 6 months, it goes on. So side effect profile is there, but baki morbidity is procedure related. So coming to another topic of debate which has been happening in at least urology and uro-oncology circles, en bloc versus conventional TURBT. This has been happening for a good time, and it started with laser en bloc, and then nowadays with bipolar, and people have also started doing it with monopolar. So the numbers here were pretty high, and the 2 techniques for removal of bladder tumors, it was found that in tumor removal in single piece provides a better quality specimen for pathology and fewer complications in comparison to the conventional method. So probably there were 2 questions in this one line, better quality specimen for pathology. If I ask this to Dr. Aditya Pradhan, one was a surgeon using his experience and doing a good resection. Second thing is having a good pathologist who will give a proper report. Because we see so many pathology reports which keep on changing. We had done a TMH study when I was there, and about 25% reports used to change if we do an internal review.
So what precisely is your question about
So
these
question was, en bloc gave a more muscle, a report of muscle being there or either positive or negative. So the question was, how do you relate it to the surgeon experience as well as the pathology, oncopathologist experience?
So yes, I would say that
I'll just add to it, like when these papers initially started coming, beware of thought that with the way we resect and the way we have pathologists at Tata Memorial, we never had the dearth of thinking why we should go for an en bloc.
Yes, I agree with you. The question first is the surgeon's experience. If you are comfortable doing en bloc, you would be able to provide a better specimen to your lab. We have got data on that, and your own personal experience tells you that. Obviously, there's a limitation of the size of the primary and location that you are comfortable doing. Most of us would be comfortable en bloc at up to 2 centimeters or maybe 3 at a pinch, but larger ones, I personally am not very comfortable. Lateral wall, base of bladder, we are comfortable. Doing dome, we are not comfortable. So I think an individual surgeon's own comfort level, and then the instrument which you are using a loop or a laser? You may not be very comfortable using a loop in all locations. So I think that adds up to the first thing, surgeon's experience and the instrumentation that you're using.
So if I ask you about the dome area which you feel uncomfortable,
Yes.
would you do the perfect resection in conventional?
I would be able to execute better.
That was what I was asking.
Absolutely. Regarding pathologists, yes, we see that. And in fact, we have sometimes sent slides for review to other centers where the deep margins are not being clearly defined by our pathologists. We have
Right.
had to take secondary insights.
So that is a pathology related problem. Even this study had a problem with that. So-
One point more I want
Yes,
to
sir.
just add here. They claim that 87% or something, they have found the muscle in the specimen. My question is, relook cystoscopy. Suppose your histopathology has come as a high grade tumor. You think that if I'm doing en bloc, why I should do a relook cystoscopy? It should be done or it should be discarded now?
Yuvraj, what is your thought on that?
Yeah, what sir is saying is right. I don't know. In my personal opinion, whether you do E-block, whether you do TURBT, the dictum is that we have to resect it properly. That's all. So whether I don't think there is any difference in clinical outcomes whether you do E-block or a normal TURBT, because as long as you remove all the tumor along with the base, I think both should be the same. There
Okay.
should not be any difference, according to my opinion. So when we choose TURBT, when they do E-block, they will not choose patients having multiple tumors around. And definitely, when you do re-cystoscopy and re-TURBT, there will be some tissue which will be left behind in normal TURBT. So that is the reason, that is the flaw of this study. So E-block, they choose only one tumor, very nice tumor. Whereas in TURBT, we choose everything.
So again, absence of detrusor muscle in the ETURB 19% was a surprise, and probably I think that also relates to
It
the
is just a surgical technique.
surgeon experience. Obturator reflex difference. I think
that is the
it
only one
relates to use of laser versus use of diathermy.
Yeah, if the patient is having lot of obturator reflex, and then we are unable to do the TURBT, then only one situation you can use the laser and get away with that. If you have a experience of using it,
Yeah.
otherwise, I don't find anything different. But it is one of the surgical technique you can follow.
Right. So I think the convergence were probably because of the reasons what Dr. Aditya Pradhan already mentioned, difficult sites were great. And the take home has already been told by Dr. Yuvraj, probably. So coming to the next comparison of sequential gem setup in docetaxel versus BCG in BCG, these were BCG naive, I think, patients. So for this particular paper, I think the comments given by Dr. NP Gupta sir were already taken well. He had given 3-4 points on that, but let us go for the discussion. It was a retrospective. CTCAE stratification of AEs was not absolute. Longer BCG follow-up. This was brought out in the presentation. So this is just to ask Dr. Aditya Pradhan sir, what is your current practice?
So intermediate and high risk. In the intermediate risk, we tend to use, if it is favorable group, we are using mito. Others, we are using BCG. High risk, we are using all BCG.
Yeah.
The only situation where we have had patients converted to gem-dosi doublets was intolerance or BCG recurrence. In those, we have used gem-dosi.
So if you see that table, the gem-dosi has done very well with relapse-free survival. But as Gupta sir said, we don't have a shortage. And as Dr. Aditya Pradhan said, still many times we would probably consider BCG. So is there any particular patient, Dr. Yuvraj, we can still skip and go for a gem-dosi? You think if you have done a large resection maybe and you give BCG even after 3 weeks, those complications will trouble you?
No, so I have not used gem-dosi at the word go. So we always use BCG. If they fail, then we go for gem-dosi. But from the word go, I don't think that is the way we treat nowadays. I
But
think
probably the Western counterparts might just be
I
going
think
for
if
gem-dosi.
1 or 2 doses of BCG, but the patient develops some side effect, then we can stop it and switch over.
Yes, sir.
Yeah, only one, two things here specific to this article which we are discussing. See, the BCG doses also they have mentioned. They have gone down to 1/10. And
They've added interferon, 1/3 dose with interferon.
They have added interferon. So are we strictly actually saying BCG has been adequately used to
So
compare?
there was an article published by Gagan Prakash in Indian Journal of Urology, and it does say that 40 milligram is also a doubtfully okay dose actually, because of, if you see the 1 vial of BCG, it has that much into 10⁻³ to 10⁻XIX colonies, which is a huge thing, although we are initially...
Ganesh, I have only one question really.
Yes, sir.
Now, suppose if you were asked a question that can we use gem site and all these things as a primary? And that perhaps one indication is intermediate. not high risk. High risk has to have BCG.
Okay, sir, but in intermediate, maybe even simple
Even
single
mitomycin.
mitomycin or
Mitomycin.
single
Yeah, but-
gemcitabine will work very well. Sometimes
No, but again, the mitomycin or gemset, that will be
Because-
the one I would go for.
because
Rather
the
than,
combo therapy will be a side effect giving therapy also. Docetaxel is an irritant.
I've not tried though, but that could be one area.
So I had one more question. If suppose we use gemdosi in the
Ganesh,
beginning,
one more indicator, what I use is beyond 75, old age people, very old people, I usually go for primary gemdosi because of the
just beyond 75, or you see at
If
the
he's,
other factors also?
other factors also.
Because
like,
just
he's-
75 nowadays people
No.
are young.
not 75 like that.
You are just writing them off.
Not 75, like if we are very, the performance status is poor, I straight away go for primary.
Agreed. So, I mean, it's a clinical call, but you may not want to just give up the BCG. What I was going to ask is, suppose you use gemdosi, maybe you can also contribute to that. And there is a recurrence, high grade recurrence. Obviously, you have early cystectomy. That old patient refuses early cystectomy. Then what? Okay, but you have a pembro option also. I mean,
Absolutely.
okay, this is the DABLACA 13 study, intensive chemoresection versus standard. So there was a history of having TA low grade or TA high grade NMIBC, and in the recurrence with more than one tumor, these treatments were randomized. Lack of A data, open labeled, small number of patients. So technically it replaces surgery in that step. The other arm has surgery with adjuvant therapy. Aditya sir, when you do a surgery, you again get the depth. Suppose you have a TA high grade. I do a surgery. I get a TA high grade, has different implications. I get a T1 high grade, it is progression. The advice might change. I mean,
Absolutely.
for a TA high grade going to T1 high grade, I will strongly advise cystectomy.
So this is one of the flaws which they have acknowledged in this paper, that it is not been checked for the depth. They've not done an MRI. It is conventional cystoscopic impression that this is a TA and therefore they are safe to go ahead. Second is the population. See,
Right.
by and large, they are suggesting this to be used in elderly patients who are not good surgical candidates. So
Maybe that is one point.
Yeah.
And if you say depth other than surgical resection, MRI, so MRI post earlier resection has its own fallacies. The first MRI probably is the best, like MRI after BCG has a problem.
this is a flaw in that.
So I think the second question relates the same. Would you be comfortable? Yuvraj, would you be comfortable? Like, anyways, net benefit of this study?
The net benefit is
I
saying that
think
you can.
it's difficult to apply it as of now.
So
And
just
lot of
what we're saying is-
limitation.
What I think the only conclusion we are drawing out is that you might not require the patient to go back to the theater for ET or VT. Do three installations in a week, 2
Right.
weeks, and leave the patient alone. Maybe safe in an elderly patient, not good for surgery.
Maybe. But it might go the other way also if it is not responding. Robot assisted RC versus with totally intracorporeal urinary diversion versus ORC, 3-year study, which Vivek presented in a very nice manner. So single center, 116 patients. Going to the questions. So slightly underpowered single center, nighttime continence as Vivek showed. So these, I just wanted to show these papers. These were the earlier papers where we matured to the thought that robotic should probably be done, but the results were almost matching except in blood loss, EBL, and the length of stay probably. So 2-3 papers here will have Vivek's name only on it. Going ahead. So this was one comment in the IJU done by Satish Ranjan, AIMS, and then we'll go to the questions. In developing countries like India, where there is no universal coverage of health insurance, the true benefit of robotic surgery is questionable due to lack of uniform data on outcomes and individual cost. I'm not discussing this statement. Yuvraj, you do a lot of robotic cystectomies. So anything more you get from this study in your practice, for your practice?
I think the study has shown that it is almost equivalent. So I think we can see our patients. So now, even in our hospital, we are publishing it now. So you could see the patients who are undergoing open and robotic. There is a clear difference, especially blood loss, as is mentioned there. Duration is less now. I think we do intracorporeal within 3.5 hours.
Right.
And patient outcomes, especially perioperative outcomes, is the patient early feeds, rails tube removal, pain score, everything was different in our study. But we are not compared with the ORC at all because we don't hardly do any ORC. But when you compare to the data which is available, I think it fares better. But oncologically, it is the same. So there should not be any difference.
Okay. So, Dr. Aditya Pradhan, coming to you now. You have a patient for cystectomy. How would you counsel a patient? With all this data coming up, patients read everything, daughters and sons Google everything, and they come with all these trials.
So my counseling depends on two things. One is the patient's surgical tolerance to a long surgery, which will be part and parcel of robotic platform. The second is obviously the cost analysis, which is a big part of our counseling to any patient here. So if a young patient who is fit and who is willing to afford, yes, we will go for a robotic platform. Elderly patient who will not tolerate a long surgery and patients who are not going to economically be able to afford a robotic, then they automatically go for the open system. That's the way we.
Just sideways question. Will patient's insurance limit affect your decision?
Yes, definitely. 100%.
He said no, you said yes. Just last 2-3 questions on the last topic.
Patient.
So this is about both the papers of trimodality bladder preservation, node negative and node positive. So Aditya Pradhan sir, you have a patient node positive, node negative. Do you counsel about both, or in which patients you will counsel about both?
No, let me be honest. The counseling regarding the trimodality is weaker in my side. We tend to be more aggressively promoting surgical management. We do tell them this. I'm not apologetic about it. There are a couple of reasons. First is your own surgery, your own radiation centers experience, the acceptability for patients to actually consider that, because they have many of the patients have come to us with a reference from outside centers with the bias already there. And they would like to consider surgery first. So we are definitely biased towards a surgical approach. I would have to admit that.
So let me ask this question to the radiation oncologist. The same question. A patient comes to you. Do you counsel about both? Dr. Naman.
Good morning. See, this patient should be suitable for a conservative procedure, organ preservation. So organ preservation requires few things. That the disease should not be extensive and the patient should be eligible to receive the chemotherapy.
No. So question was not that. Question was, will you counsel about both or not? Because the next question is to you only. What are the selected cases?
So in present day, we should explain the patient about the possible treatment option.
Okay.
And then we should choose patients based on the best criteria the patient is eligible for.
Okay.
And if we don't follow this path, we are going to.
Because why I said this? Because in India, the practice is skewed. One thing what happens is whoever the patient goes to does the thing.
Sir,
Secondly, what practice is skewed in India is that many places, even the surgical expertise in slightly towns is not available. So surgeons would refer to a radiation oncologist for a bladder case, which still happens in India. So that is why these questions were asked.
Sir, at my institute, like I'm working at NCH and AIMS, both places, we have a TMG-based practice. So we do discuss cases, and depending on the best possible option, the treatment choice.
So to the other radiation oncologists, what is the selected case for you, which you should have in your practice, where you will produce a good result with radiation or bladder preservation?
So definitely patients with without any evidence of severe to moderate hydronephrosis.
Okay.
Disease should not be multifocal.
Right.
And in some of the papers, they have said that ideal size for opting for TMT's size of tumor should be less than 6 centimeters.
Okay. But then again, Dr. Supriyo, are there any cases which radiation oncologists would not consider for trimodality, multiple tumors and all, or then?
Sir, of course, this kind of patient, multiple tumors, the patient are really not a good candidates. Multiple TCI kind of thing,
Okay.
level polycystic bladder. They better should be offered.
So the fourth point actually was brought about by Gupta sir, and I would like to ask it to Yuvraj. So do follow-up protocols would matter, because as you know, surgery, the bladder will be out. The follow-up protocols will be
No, that
different.
should be very stringent here.
But
to
in
identify.
radiation,
That should be very stringent. So 3 monthly scopies and imaging at least once in 6 months, either CT scanner, but it's a must here.
it's a must. So all these should be ingrained in patients undergoing trimodality and bladder sparing treatments.
Ganesh, can I just?
Yes, sir,
ask you one
please.
thing? See, we are more familiar because we are all surgeons here. We are more familiar with our data about what we are doing and how are the outcomes in our patients. Can I say the same about our radiation centers? Large
Also-
volume centers like you have worked, you have enough experience
Yeah.
to actually give them a balanced advice.
So very honestly,
places like
if you're talking about the follow-up
No,
thing,
I'm just talking about the quality of execution of
Okay.
trimodality. Here it very strongly depends on the quality of radiation coming out
Okay.
from your center.
so I have a small comment on that. So as the surgical papers also should say that bladder cancer treatment should go to high volume centers. I think even in the radiation, it should go to centers who are used to and well established with giving that treatment. And secondly, yeah, please. You want to make a quick comment? We are time out. Huh?
Sorry, sir, I'll differ with you. It is not radiation. It's all treatments, be it surgery, be it radiation, be it immunotherapy. If the patient is in not the right hand.
No, so that I said already. So you have any more comment than you make? No.
If an institute is performing radiation properly with the modern kind of machine, radiation is not a tool that can be underestimated.
So that
We
is
should
true.
offer the
So-
basic.
Dr. Supriya, what I was trying to say is in TMH also, we had a doubt about this follow-up protocols. And about, I think 2017, 2018, I had asked this to Dr. Vedang. And then we sat together and created a strong, stringent follow-up protocol. But I used to see, Dr. Mahendra is not here right now. Till then, we have seen that the patients were randomly followed, randomly cystoscopy, randomly cytology. And the axial imaging was also very random in patients who were radiated for bladder. And this was at an apex center. So now we have a protocol which is stringent, but I hope it is followed up everywhere else. Sir,
No, one point I want to highlight here is 1986 in AIMS, the Rotary Cancer Institute, we started tumor board, urology tumor board. So he is from Jajjar, that is the National Cancer Institute,
right, sir.
so under the guidance of the AIMS. So I'm asking this question, are you discussing every case in your tumor board or not before deciding the treatment? What is the policy now? And why not these high volume centers we are talking about here? Why not they should have this tumor board practice?
Sir, at NCI Jajjar, it's all tumor board based practice. So all the patients, they come directly to the board. So we don't have separate clinics for departments. Like for any disease, be it head and neck, be it breast, be it any uro. So we discuss in the board. And that consists of radiation oncologists, medical oncologists, respective surgeons, radiologists, nuclear medicine, and we are waiting for pathologists, more number.
I think we'll take Dr. Ginil's comment and stop it.
Yeah, I'm actually a fan of trimodal treatment, but initially, whoever have sent to radiation oncologists, I don't have any follow-up those patients. That was one thing because of which I was dejected. So I feel that if at all it has to be practiced in Indian scenario, it has to be to highly selective patients where if you are skipping a few, there is a high possibility of cure. And we have to, like Shipley's article, based on that, we have to rule out carcinoma in situ, hydronephrosis, large.
So well selected patient.
Very selected patients. If we are losing the patient, there should not be any severe issue. And the patient should be very much, the counsel such an extent that they should come back, and the strict follow-up is the issue with blood preservation protocol, not the cure. And also in the British study, if you see, even though they are discussing about radiation in the high-risk individual, all patients can be taken up. The percentage of patients who had high risk compared to the complete resection T2 was minuscule. Only a few patients had. Based on that, probably the Shipley's articles are a better criteria based on which we can plan, not the British study.
Thank you. I think we can discuss for a long time, but let's stop.